All right, so many governments imposed lockdowns, especially in their response to the first wave of the pandemic in spring 2020. So by the 5th of April, so just a bit over a year ago, 57% of the world population was under lockdown. That is 4.4 billion people. And you can ask, were governments actually justified in locking down their citizens in this way? And so philosophers have started asking this, and many of them have argued, here there are two examples, that these lockdowns were actually not legitimate policies. Now we want to ask kind of the opposite question, namely, what can be said in favor of lockdowns? Can lockdown decisions actually be justified, at least in some places? And to make this a bit more concrete, we will look at the lockdown decision in the UK, and we will talk about the kind of reasoning that led to this decision. And then we will consider two philosophical challenges to this line of reasoning. First, arguments from political philosophy that restricting liberties in this way isn't justifiable. And Lucie is going to talk about this. And then Mathias will look at an argument from the philosophy of science, namely that the evidence was too poor to justify lockdown. And we will argue that both of these challenges can be met. Okay, but so let me first say a bit more about the actual lockdown in the UK and how the decision to impose this lockdown can be reconstructed. So in the UK, people were not allowed from the 23rd of March to leave their homes, except for shopping basic necessities, and the other shops had to close, to do exercise once a day, to attend medical needs, and some other exceptions. Schools had been closed already before on the 20th. And if you violated these rules, there were fines of up to £6,000 in England. So these are very heavy restrictions of your civil liberties. And they also had severe consequences for the economy, for public health. And the main reason for imposing them was to prevent the healthcare system from collapsing, avoid situations like the one in Italy where this was happening, and they were by the time using triage. And so it was clear that quite early on that this was unlike the seasonal flu, and especially the elderly were severely affected. Now let's have a look at this decision table here. This is a simplification of the situation, but I think it reflects the most relevant considerations. So in the weeks before the lockdown, there was a lot of talk about herd immunity strategies or mitigation strategies. That is, you reduce the reproduction rate, but not to below 1. And so if that was sufficient to keep the NHS from becoming overwhelmed, so if you're in the state of the world on the right-hand side of this table, then lighter measures would be preferable, because you don't need lockdown to prevent a public health catastrophe, and at the same time, lockdowns are very costly. However, suppose your suppression is needed, that is, you need to push the reproduction rate to below 1, otherwise the NHS would be overwhelmed. Then in this case, the lockdown, of course, still entails costs, but a more severe spread of the virus also causes significant costs. So not only does it overstretch the NHS, but it also causes economic damage. Now, it wasn't clear how these two kinds of costs would compare, but even if you expected that the costs from the lockdown would exceed those from the additional viral spread, there were reasons to think that this difference couldn't be larger than the costs from the public health catastrophe. And one reason is that some of the costs from lockdowns can partly be contained in countries like the UK, for example, through short-time work or other economic aid schemes. But a public health catastrophe can't be contained in this way. So the possibility of this catastrophe should really guide the decision in this case. And so you should impose lockdown. So what the optimal choice is really depended on which state of the world we were in. And of course, we didn't know with certainty which state we were in, but there was an asymmetry of evidence here. So there were models, for example, one by the famous ICL group around Neil Ferguson, that suggested that we were in fact in a scenario in which suppression was required. There was also observational evidence that locking down early on could make a difference in preventing an over-demand on healthcare systems. But there was no comparable evidence that we were in a scenario in which mitigation would suffice. So there was, this kind of preponderance of evidence on the left-hand side here, and this provided an argument for lockdown. Now, there are two main objections to this argument. You can ask whether looking at things in this kind of cost-benefit way is legitimate, especially when the evidence was still uncertain, emerging, and because lockdowns involve such severe restrictions of liberties. And Lucie will talk about this in a second. And then Mathias will talk more specifically about whether models such as the ICL one provided good reason or good enough evidence to support this argument. But now I hand over to Lucie.
Great, thank you. So the first objection here is that it's just not justifiable to restrict people's liberty in such a drastic way, maybe based at all on a cost-benefit analysis, but certainly based on such tentative evidence. And we can see an example of this in a paper by Eric Winsberg and colleagues against lockdowns, where they argue that freedom is the default from which departures must be justified. The greater the imposition, the stronger the justification needed. So let's take each part of this in turn. First, when can you justifiably curtail people's liberty? And second, can you do so on the basis of uncertain evidence? Now, it's quite widely accepted that the state is justified in limiting people's liberty when they pose a risk of harm to others. And this is known as the harm principle. It should be noted that one doesn't have to intend to cause harm for restrictions on liberty to be justified under the harm principle. The risk of unwittingly passing on a dangerous virus to others could qualify as putting others at risk of harm. But another condition needs to be met here. It is not just putting people at the risk of any harm that justifies implementation of the harm principle. After all, we do this all the time in ways that are commonly regarded as legitimate by, for example, driving a car. Rather, in Feinberg's words, what justifies restrictions on liberty is the unreasonable risk of harm. So in order to know if restricting people from going about their daily business during a pandemic can be justified under the harm principle, we first need to know what constitutes an unreasonable risk of harm. So one popular suggestion comes from risk theorist Sven Hansen, who is concerned with distinguishing between what he terms acceptable and unacceptable risk. He proposes that the exposure of a person to risk is acceptable if and only if this exposure is part of an equitable social system of risk-taking that works to her advantage. The idea here is in exchange for being exposed to risk by, for example, others being able to drive a car, I am also allowed to drive a car and expose others to the attendant risks. This is justifiable because we might presume it works to everyone's benefit. Such a principle could be used to justify targeted quarantine measures. Allowing a person who we believe has a dangerous infectious disease to go about their life unhindered poses a risk to others, but with no corresponding benefit, and thus constitutes an unacceptable risk in Hansen's terms. But we might think that this falls apart when we are talking about general restrictions. After all, if I am free to go about my business, exposing you to risk, you are also free to go about your business, exposing me to risk. Perhaps this scenario is more like driving a car, where everyone is exposing each other to risk, but where this is ultimately working to everyone's benefit. There are a couple of problems with this, however. First, as we have seen, even early evidence suggested that certain groups of people are at a much higher risk of serious complications or death from contracting COVID. Could you switch the slide, please? And even if they take all possible measures to avoid contact with others, their risk is still increased by allowing the spread of the virus through the community. This should lead us to doubt that this conduct would be part of an equitable system of risk-taking. Now, even if we reject this argument and maintain that COVID in this respect is no different to the seasonal flu, we need to take into account the risk also suggested by this early evidence that not locking down early could lead to hospital systems becoming overwhelmed. If we factor in the additional risk that you will not be able to access medical care, in addition to the risk of contracting COVID, it becomes less likely that people should view taking on these risks as ultimately working to their benefit or advantage. But one might think this is not the core problem here. It is rather the fact that this evidence, particularly at the time that lockdowns were first instituted, was highly uncertain. After all, Winsberg and colleagues take issue not just with the fact that limitations on liberty can be justified, but they rather focus on the claim that impositions on liberty require strong justification. We might therefore want to maintain that more evidence needed to be accumulated before lockdowns could be justified. The problem with this is that the admittedly limited and emerging evidence suggested not just a risk of potentially serious consequences, but that this risk was imminent. And in situations in which risk was imminent, refraining from action until further data is gathered can effectively preclude the possibility of acting to mitigate the potential harm. Now, we do need to be cautious about the exercise of such state powers, but there need to be some provisions allowing governments to act quickly in the face of a potential imminent threat. Now, all this is premised, of course, on the idea that there was some evidence here. But as we've already seen, particularly yesterday, some have argued that the models, which were really key pieces of evidence in the decisions to institute lockdowns, were so problematic and poor that they should not count as evidence at all. So in order to tackle this objection, I will turn over to Mathias.
Okay, thanks. We have so far argued that epistemic standards governing acceptable evidence ought to be relaxed in situations of extreme urgency. Now, one type of evidence that played a particular prominent role in policy decisions was the output of epidemiological models. Yet some have so heavily criticized these models that one may worry whether the putative evidence such models were able to provide was too poor to clear even a significantly lowered evidential bar. Thus, a research group involving Stanford's John Ioannidis argues that the performance of models, at least early on in the pandemic, was too inadequate for results to be passed on to policymakers. Winsberg et al. In the paper we already cited say that the maintain that models are flawed and that epidemiologists failed badly. The economist John Cochrane claimed in a blog post that SIR models are completely and totally wrong. And we heard yesterday that we should have assigned 0 epistemic weight to COVID-SIM, the Imperial College Report 9 model. So was the evidence models provide then too poor to be considered in policy decisions? In the last couple of minutes of this talk, we want to defend the use of models by arguing that at least some of the criticisms of models reflect an overly narrow conception of the purposes models may have. Epidemiological models can play a legitimate role in informing policy decisions, even if exhibiting some of the flaws to which critics drew attention. Critics of models tend to compare models with empirical evidence and then conclude from a poor fit that a model fails. This suggests that the only purpose of models is to predict outcomes, and do so as precisely as possible. But this is too narrow in two senses. First, in the demand for maximal precision, and second, in the restriction of models as tools for prediction. Beginning with the first point, it is by now a well-rehearsed point that models idealize and abstract, and that there is no perfect model. But this means that what we count as sufficient precision is dependent on contexts of use. We might want a model to yield extremely fine-grained predictions, but we might also be content with coarse-grained, order of magnitude, or merely qualitative predictions. Moreover, and this is the second point, models are not only used for predictions. It is customary by now to distinguish predictions, which are statements concerning the values of quantities in the actual world, from projections, which use non-actual inputs, either non-actual initial conditions or non-actual parameter values, to output the value of some quantity under counterfactual circumstances. And projections too can play an evidentiary role in policy decisions, for example, by exploring the range of plausible outcomes in the context of broadly precautionary decision-making. Now, some of the criticisms levied against epidemiological models are the result of treating highly idealized projections as predictions. Many models abstract, for example, from spontaneous or endogenous changes to social interactions. This is actually the reason why Cochrane claimed that models are completely and totally wrong, because they ignore such spontaneous changes. Yet the abstracted models are not meant to provide fully accurate representations of the evolution of social interactions, but nevertheless, they can serve a legitimate purpose. They allow us to investigate the causal effect of various changes in social interactions on the spread of infections, while abstracting from the question through which combination of policy measures and spontaneous behavioral changes the changes in question can be brought about. Similarly, the claim in COVID-Sim, Ferguson et al. In 2020, that there could be up to 2 million US deaths, a number that critics have claimed is wildly exaggerated and much too high, is not a prediction, but a projection for a do-nothing worst-case scenario in which, as was pointed out by Jonathan Fuller yesterday, we assume that everybody, including everyone on an individual level, in fact does nothing and doesn't change their behavior. These numbers thus function as counterfactual limiting case of the death toll under a completely uncontained spread of the virus, and to be sure, unrealistic limiting case that may nevertheless play a role in anchoring our perceptions of the severity of the threat posed by the virus. Now, what about the accuracy of any such numbers? Winsberg and co-workers worry that parameter choices in models were entirely speculative, but we want to contend they were not purely random guesses. Rather, they were based on expert judgment, underwritten by experts' experience with other diseases and the limited early evidence and experience with the type of models they used. Should we trust expert judgment? Well, given the dearth of empirical data on SARS-CoV-2, it would have been a mistake to treat model outputs as offering numerically precise prediction of infection and fatality rates, or of the strengths of the causal effects of various NPIs, non-pharmaceutical interventions on these rates. Yet modelers and policymakers arguably were warranted to take model outputs to provide coarse-grained order of magnitude or qualitative information about the spread of the disease. Models were able to provide legitimate support for conclusions like and not mitigation can prevent hospital resources from being overwhelmed, as Jonathan Birch also argued in discussion yesterday. Indeed, now, post hoc and much later than March and April of last year, we do have evidence that trust in this type of use of early models was in fact warranted. A robustness analysis of COVID-Sing by Edeling and co-workers shows that if we vary parameter values, most of the resulting probability mass contains predictions with an order of magnitude similar to the predictions of the scenarios in report 9 by Ferguson and others. Parameter values may have not been well constrained empirically, but if considered in an appropriately coarse-grained manner, parameter choices did not significantly affect the model's output. Also, Ioannidis and co-workers show, interestingly, for the case of predicting fatality and hospitalization rates in New York State, and that's the paper that has the output that models failed, that the mean absolute percentage errors of the model's predictions were mainly less than 150%. This observation counts as evidence for model failure, only if we assume an overly narrow conception of what can count as modeling success. All right, this concludes our talk right in time. Summing up what we have argued here, emerging evidence in March 2020 suggested that the benefits of lockdowns outweighed their costs, but then we addressed two objections. First, we can't restrict people's liberties on this basis, and we argued that these restrictions can be justified when the conditions of unacceptable risk of harm and urgency are met. Second, objection models were so problematic that they shouldn't count as evidence at all. Here we argued that while there were problems with the models, they can count as evidence as long as we understand what they can or cannot do. All right, thank you for your attention.